Irreverent, entertaining, cool. You're listening to LA Talk Radio.
You're listening to The Inner Voice with Dr. Foojan Zeine, only on LA Talk Radio.
Hello, everyone. I'm Dr. Foojan Zeine, and welcome to the Inner Voice Show. Now, this show is about making a difference in your life so you can create a free mind and a heart filled with love toward creating a fulfilled life for yourself. Now, I'll bring you the latest research in the realm of human sciences, and we'll talk to experts in their field to bring you the jewel of their knowledge and their wisdom. Now, before that, let me tell you a little bit about my latest book, Life Reset, The Awareness Integration Path to Creating a Life You Want. Now, that comes with the latest psychological model that's been presented to you in a series of exercises, which you can complete in your own time. The awareness integration, we've done a lot of research and published it with many groups. And the latest one has been with 120 students in Cal State Long Beach. And we got results of 68% minimizing depression. Isn't that awesome? And 27% reduction in anxiety. That wasn't even a form of therapy. That was just self-help. It's exactly what I'm giving you in the Life Reset book. So I hope that you get it. And if you want, go to Foojan.com, Foojan.com. And if you like to consult with me, my offices are in Irvine, Woodland Hills, and Brentwood. And I do see and consult in my office and online. So love to see you and love to talk to you. Now, I have Cynthia W. Hammer with me. She is a radio host right here in LA Talk Radio. Wednesdays, the same day at 2 o'clock. I met her in the studio right before I was leaving at the elevators. And this woman is like a powerhouse. She just said, hello, and let's get together in our shows. And I'm like, awesome. That is wonderful. Now, her show, the name of her show is Hammer Away. Hi, Cynthia.
Hello.
How are you?
I'm wonderful. Thank you so much for having me.
It's nice to have you. So tell me about your show.
Well, Hammering Away, of course, my last name is Hammer. So Hammer Away is about there is no instantaneous way to success. Everyone wants to be on the top, but they don't want to do the middle. So people wonder, how did you accomplish what you have accomplished? We have questions for our friends that have success, and people have asked me, because I'm also an author. I do many things. So Hammer Away is about how you chip away at success. Ooh. It doesn't happen overnight. So we will have guests that tell us how they did it. And, other interesting topics, we'll do musicians, actors, scientists, education. Let's change the narrative in this country and start talking about the great things that people are actually doing and not beating each other up.
Right. So everybody's looking for the 15-minute fame, but then they look at they look at the end and they're like, I don't understand. How did she get onto the top? How does he do it? But then there's like 20, 30 years of work behind it.
Yes.
And that's what you bring. You bring the wisdom, the tools, and you talk to people so they can show the audience in what it is, the listeners, in what it is that they actually do, and everyone can take their own path.
Yes. Absolutely.
That's awesome. Tell me about your book.
Okay, so A Good Case is a behind-the-scene look at the billion-dollar home health industry in senior care. Mm. Yes, it's about 2 caregivers working in Los Angeles. Mm-hmm. That is available on Amazon, Arthur House, and all booksellers online. My first novel, Iceberg, is based on bullying. And that also is available online, all online booksellers. And, I'm on Twitter and Facebook at Hammer Cynthia, Cynthia W. Hammer, author. Awesome. Easy to find. Just Google me. Awesome. And I'll be here at LA Talk Live Wednesday, Channel 1 at 2 p.m.
Channel 1 at 2 p.m. It was such a joy to have you here. Thank you. Thank you for coming and starting my show today with me.
Thank you for having me. Have a great show.
Thank you. All right. So now I want to tell you the latest research on pain management because my guest, Michael Munion, will be talking about pain management. So the new study in the Journal of Internal Medicine says that after participating in a single 15-minute session of mind and body therapies, mindfulness training, and hypnotic suggestions, patients reported an immediate decrease in pain levels, similar to what are expected actually from opiate painkillers. Now, that's amazing. Now, so we're going to be actually talking to Michael Munion. Let me tell you a little bit about him. Michael has been practicing psychotherapist since 1979. He is also a veteran of the publicly funded behavioral health system for more than 30 years. In that arena, he was active in developing and implementing an integrated primary and behavioral health care model in Arizona. He's a co-author and co-editor of 2 textbooks on psychotherapy geared for practicing professionals and graduate students. He has trained professionals internationally on Ericksonian approaches to psychotherapy. Currently, in addition to the private practice, he's a chief psychology officer for the Pain Project. This effort is designed to bring non-pharmaceutical interventions to individuals who suffer from chronic pain. The drastic overutilization of opiates for the treatment of chronic pain has both contributed to the national epidemic of opiate addiction and opiate-related deaths, and a failure on the part of the medical community to provide effective interventions for chronic approach. The Pain Project approach. That's what we're going to talk about with Michael Munion. Hello, Michael.
Hello.
Hello to Arizona.
Hello.
How are you?
I'm well today. It's a beautiful day in Arizona.
Oh, great. You know, I used to go to school there. I went to high school and I went to ASU. So Arizona is my second home.
Nice.
Well, I met you in Arizona at the Ericksonian.
That's right.
And it is great with your new project because it is so necessary, especially now that it just seems like United States has this type of an epidemic. I know that my original home was Iran, and we had one of the highest opiate addictions around the world, I think. And then after that, I think Afghanistan had it. But who would have known that United States would start leading the edge on that? And I'm so glad that you are working in the next phase that needs to be created for the pain management and possibly addiction, because that's how it all starts.
Right. And our effort really, I mean, it was twofold. It was partly in response to this opiate epidemic, and then, of course, partly in response to the fact that people aren't really getting the relief that they could use with chronic pain. At this point, the statistic is something like 4 out of 5 individuals who are now addicted to opiates and addicted to heroin began as prescription drug users. And so that is, radically inflating the number of individuals who might be addicted to heroin, because frankly they get cut off from their pharmaceutical supply and they end up going to the streets.
Yes, and the other side of it is that those painkillers, because of operations, because of pain, because of many aspects that people get into hospitals or their doctors, they're being also administered and given very much freely with no other life change or life changing behaviors that are beside them. So people are just going after very, very easy fixes in order to calm down their pain, but they're not necessarily learning how to cope with the pain, manage the pain, or even alleviate the pain in any other way, or manage their life in a way that even calms down the pain.
That's correct. And it, in its own way, that phenomena speaks to one of the fundamental principles that we like to work with in the Pain Project, and that is is the source of my relief external or internal? And as long as we're looking outward, we persist in going to physicians and saying, I need a drug, I need a medication, something outside of myself to relieve the pain. And so we don't look at ourselves as an agent of change. And that's a real important thing across the board. It's equally true with things like PTSD. If we're looking for something out there to fix it, we almost always founder with that.
So shifting this focus would also create some sort of a responsibility and accountability for the people, for the patients who are feeling pain. I remember going into the ER because my nose was bleeding. And after I came out of the ER, the doctor gave me prescription. And it was for Vicodin. And I didn't understand why that was. And he says, well, people usually come to ER and they're in pain and they get this. And I'm like, okay, but I had a headache, but I got Vicodin. And then another time I had an operation, and because of the operation, they prescribed Vicodin for me. But when my friend went and got it, they automatically gave me 60. And so what was it wasn't necessary to have 60 Vicodins. So part of it is that the external world is offering it, whether you're getting it through the physicians or hospitals or you're getting it through the streets. There's always that outside of us. But there's also the responsibility of knowing that if a prescription drug is addictive, or if I have an addictive personality, how I would be using it, and when is it that it's enough to bring down the pain, and when is it that it becomes part of my lifestyle, or when is it that I'm utilizing it or using it as an addictive method and as an excuse.
Absolutely. And just to amplify your point, and of course our data is always lagging by a few years just in what it takes to get it all together. But in 2012, there were 259 million prescriptions written for pain medication in the United States. And that's enough for every person to get a bottle of pain medication and in 1 year. And that was twice as many per person as were written in Canada. So it speaks a lot to our prescribing practices. Like you said, you went into the ER with a bloody nose and a headache, and you came away with Vicodin. And I'm not sure why Advil or something else might not have just done the trick for your headache. It was really the bloody nose that needed care. Is that right?
Yes, and Michael, I have I work with addiction, so I have had a lot of my clients who have had different types of surgeries, and although they were completely sober for many years, right after they had the surgery and they were appropriately even prescribed pain medication, it induced all of the addiction patterns and the cravings again. And they have relapsed right after any of these medical conditions have come up all over again. So it's like we've talked about revolving door many times, but I also think that many of the physicians might not necessarily know about the dynamic of addiction. They're concentrating on relieving the pain that their patients have, and they want to take care of them. However, they're not necessarily trained in how the dynamic of an addictive personality or someone who has been addicted before, that this can really take on its own life. And so if everybody is not educated in how to handle these pills, then we have the epidemic concept that we have. Now you have in the Pain Project, one of the things that you do is you educate the patient about what is the distinct difference between an acute pain and a chronic pain. Can you talk a bit more about that?
Oh, absolutely, and it's a really important and vital distinction. And acute pain it's caused by a specific physical injury, perhaps, or something like cancer, typically we're looking at a duration of less than 3 to 6 months. And with acute pain, the level of pain frequently correlates with the degree of tissue injury. And the acute pain ceases once healing occurs. So it's really self-limiting. We look at something like chronic pain, and it's very different. It may or may not have to do with a specific physical injury, but typically it's greater than 3 to 6 months, and often the level of pain doesn't correlate well with the degree of tissue injury. In other words, and we can think about just some of the chronic pain conditions, arthritis, a back injury that is now stabilized, but this is one of the things that happens really a lot, is that we've got back injuries. Medically, there's not a lot that can be done that is safe, that's going to relieve the pain, and there's no further damage happening. And this is a distinction that we start right away to look at the difference between acute and chronic pain. If you put your hand on the stove, a hot stove, you're going to feel that, and you should feel that, right? Mm-hmm. Because it has a survival function.
Yes.
And that is the primary distinction between acute and chronic pain. Acute pain has a survival function. Chronic pain has no survival function at all. It is reminding us that, yes, my back has been injured, but really there's no further damage happening at this moment. It's just this constant reminder. The same is true with arthritis in our hands, fibromyalgia, so on and so forth. They differ. Chronic pain differs from acute pain in that no damage is occurring right now, and there is no tissue damage right now. But the problem is our brain doesn't distinguish between acute pain and chronic pain. And so those constant reminders feel as if there's something we need to protect, there's something we need to attend to, there's something we need to fix, when our doctors have told us your spine is as good as it's going to get, your arthritis is a static chronic condition, but our brain doesn't get the distinction. So because it has that survival function, it's kind of constantly in our awareness. And so we treat it like we treat acute pain. And when we seek medical relief like we do for acute pain. Did I articulate that distinction well enough?
Yes, especially since you're talking about, arthritis pain in my hand. Yes, I've been having it for a couple of years, so my ears are all popped up. You say in the Pain Project that you guys are able to modify and automatize our sensory experience in response to pain. So as I hear you is, if there's really no tissue damage, somehow the brain activity gets conditioned to look for the pain or recreate the experience of the pain, although that might not be, or that if the pain is there for other reasons, that instead of getting to know the pain and how to manage it, we respond to it as if everything is a torn tissue or a broken bone and all of that. So because we deal with it all the same way, we're getting the same kind of results versus being with our body and shifting it. But I'm really interested in this concept of modifying the way that our sensory experiences and the response to pain. Can you say more about that?
Sure. And there's an array of approaches that we bring to the table when we're working with individuals, and certainly very popular in today's psychology culture is cognitive behavior therapy, and we've done a lot of training with our staff about cognitive behavior therapy and how that relates with what is known as the gate control theory of pain. And boiled way down, what it says is that uninhibited, pain impulses will dominate our awareness, but that there are competing activities we can do that will diminish our sensory experience of pain. And I think that's the shift that we start to make, is that we distinguish between, again, the acute pain, which is telling us that, oh my gosh, my hand is being burned on this hot stove, with that sensory experience that is, yes, I have this chronic arthritis condition. When we can start to create competing sensory experiences so that we aren't experiencing the pain in that intense way that we used to experience it. And
so
again,
what do you mean by competing?
I'm sorry, say that again?
What do you mean by competing experiences?
I will give you an example from my own experience, and that is another painful experience that many people get is shingles. If you've ever had them, they're kind of amazing. I first thought I had a broken rib, even though I didn't know that anything that would have broken the rib. Ultimately, it kind of took up about half of my body, and it felt so intense burning, like, don't anything touch this, I don't want anything near it, was how you would experience that pain. But what I found was, if I was to rub that, what was really going on was that the shingles were sending nerve impulses to my brain saying something's horribly wrong here. As soon as I started to kind of rub the places where it was sore, my brain had to process those sensory signals as well. And it turns out that they overpowered the pain signals, if I'm articulating that clearly enough. And that's just a simple example.
I see that naturally, that people do things like that naturally, where they're in pain. They will rock, or they will soothe themselves by caressing themselves in that part, or even other parts, or they shake, their legs. And is that what this is similar to what you're saying? Is like you actually have another sensation, or you put your focus onto something else where your body and your focus would also focus in that versus the pain that is there?
Absolutely. And that's at the neurologic level. We look at the whole biopsychosocial model, and not only there, but there's this parallel cycle that's going on, and that is people with pain, that engenders fear that I'm going to have more pain. So what happens is they do less. And in doing less, they start to lose social interaction. They certainly lose their physical activity. And all these things that they lose creates this giant space in their life to focus more on the pain.
Yes.
And then that inhibits further activity. So when we talk about the physical sensation that competes with chronic pain, and again, nothing I'm talking about is appropriate treatment for acute pain, but those sensory experiences that compete with chronic pain that we were talking about with the gate control theory, it's the same with our activities and our interactions with people and getting up off of the couch. And in spite of the fact that and you spoke about arthritis and so forth, you feel it less when you're out walking and talking with someone, and your awareness is otherwise occupied. When you've got nothing to do but feel what that arthritis feels like, you're going to feel it.
Yes.
And so we start to talk about disrupting that cycle of of allowing the pain to be our dominant experience. It changes our whole identity.
It does.
If we let it.
Yeah. Even when you were talking, I realized that at the time that I didn't know what this pain was, I would get afraid. So the minute the pain was, my whole system would be shocked looking at it. What can I do with it? And it was all consumed. So when I had the answer, no, it's just, it's arthritis and this is what it's going to be. And now I've noticed that when I push my hand in a particular way or hold it a particular way, that I'll have like excruciating pain coming. Knowing that this is going to be a lifetime conversation for me, now I shift my attention immediately. It's like, oh, well, I push my hand in a particular way. All right, so I'll change it now. And then I focus on something else and move on. Like you said, the pain goes away versus the time that I would focus and kept going. And then, I would monitor it in a particular way where the pain in my hand would consume me all day in the sensation and in thought process, and therefore with my emotions because of feeling powerless against it. Versus now that I'm experiencing, all right, well, this is something that I got to live with for the rest of my life, then I experience it, I acknowledge it, and then move on. I won't do anything to bother it more, and I guess that's how I take care of myself. But then I move on. It's like, fine, I'm going to do something else. And then I get scared. Well, what about if I can't even write anymore? Okay, well, technology has given me voice, so I'll do it that way. So it's more of moving on from it and not allowing it to be upholding my life, just accepting that that's just part of aging that comes through. And this is what I'm hearing from you, is shifting and modifying that the way that we are with our body, not ignoring it, not avoiding it, but learning about it, knowing what it is, and then being another way with it, right?
That is a whole lot of it, absolutely. We have to change our relationship to the pain.
Yeah. And I even remember with a backache that at one point I couldn't move. And for 3 days, I couldn't move. And the powerlessness against the pain was more excruciating. And my brain usually just goes, what happens to my life, immediately, if this is always there. And but then having a different relationship with the pain and your body, it just seems like it refocuses it in a whole different way. And that's part of what Pain Project does. It seems like help you better understand your pain, your body, your emotions, relationships that you have with it, activities, and all of that. And then shift the way that you, your sensory experiences, and then you utilize cognitive behavioral therapy, mindfulness, and then a psychosocial assessment, so you can see the impact of that pain into other relationships and activities, and having the person really have even a compassion with their body versus get angry. Because I think a lot of times I've seen people, and I've had that experience, and I've seen people who they get angry at their body, and then they get angry at everybody else for not understanding them. So even those types of emotions, with the fear, the powerless, and the anger, adds to the experience of pain, because not only we have the physical one, now we have the anguish of the emotional one. How does the Pain Project deal with the emotional aspect of it?
Well, and we have to absolutely start with, what is this person's experience? And I think I'm going to tell you first about what we don't want to do, and that is it's couched in the communication difficulty, because one of the truths is that everything that anybody ever experiences is mediated in the brain. And all of our sensory experience, all of our thoughts, our emotions are mediated in the brain. So our entire life experience is mediated in the brain. And what we absolutely, while we want to leverage the reality that we can start to modify those experiences within the brain, at the same time, the last thing we want people to hear is, it's all in your head. Because when your hand hurts, your hand hurts. When your back hurts, it hurts. And we don't want people walking away from that first message thinking, okay, what this person's telling me is my pain's all in my head. The truth is our sensory experiences are all in our brain, but your pain is real. Everybody's experience is real, and we have to start with that. And I think you hit a beautiful point there when you were talking about the emotional impact of pain. And some medical conditions are going to require a change in lifestyle, so that someone who maybe once upon a time got their primary joy from jogging, well, maybe their injury means high impact physical activities are a bad idea, that it's going to continue to injure that body part. That's a loss, right? So now I can still get exercise, but I maybe need to do it on an elliptical instead of jogging. Well, I miss running down the road, and I miss some of the facets of that particular exercise. There are alternatives that are good and that help me out, but there's a loss there, and that's just an example. So many times, so many ways, there is not only that loss, which we have to grieve. There's depression from just having to deal with how isolating pain sometimes is. People around us don't understand. There is anxiety, as you were talking about earlier, that we're going to be hurt again, that something else is going to make this worse. And so all those emotional components need to be addressed as well. And that's why our staff are all trained therapists to help people deal not just with, here's some new techniques that you can use with mindfulness, but to deal with the emotional impact of all that. So I think that was a very astute thing for you to pick up there, that depression, anxiety are profoundly common comorbid conditions with chronic pain.
And loss of relationships also. I'm actually currently working with someone who, for various reasons, might lose their eyesight completely. And it was bleeding, and they had to do a lot of work with the eyesight, and a lot of the work they did with the needles and operations were very, very painful. But there's also this concept of not only the pain, but the anxiety of what would happen if I lose my sight. The business will go down. My whole life would go down. I have a wife. I have 2 kids. The whole lifestyle will go down. And then the tolerance is low. The tolerance, because there's all of this preoccupation that comes with what's going to happen to me in the future, which is all presumes negative at that moment. The tolerance is low for everything. So if the kids are yelling, I'm going to yell. I can't tolerate it. I just want to go isolate myself in my room. If my sisters or my wife or my husband or whomever is calling, I just don't want to deal with it, because I just want to go back home, and I want to go crawl under a blanket, and I don't want to hear anything. So in one way, I know I have to deal with life, and then I don't want to. I really just, my whole body and my psyche is consumed with this, and I don't want to. So you can see that there's an intolerance in relatedness that comes, and then so obviously the same intolerance will gradually be given to other people who are around you, who slowly but surely also will keep you isolated and prefer for you not to be in a nasty mood. And hopefully, if they can't do anything for you, at least they don't want to see you either. So, they will come and visit you for 15 minutes, and they're like, okay, bye. So you're going to lose that type of social healing that can be there, because you're being consumed with the depression and anxiety and all of that. And So it's like retraining a person and their family and the whole system into dealing with this type of a chronic pain, which will be there for a lifetime, maybe.
Right. That's very well said, and it's almost like we have to go through the entirety of a person's daily, weekly, monthly life and help them reclaim all those facets of it, their social, their vocational, their recreational, that whole functional assessment needs to happen, and we need to find ways for people to adapt. And I think adaptation is something that we look at that comes from inside towards our environment, as opposed to that looking outside, looking outward for someone to fix this for me. And the other thing that happens is that when I'm looking outside for a doctor or a pill or a surgery to make me feel better, then I feel pretty helpless. But when I am adapting, I start to feel empowered. And I think that's a very important distinction, is in terms of where are we, if we're suffering from pain, where are we looking for relief? Are we looking outward or are we looking inward? And the truth is, the Western medical model more or less trains us that we should be passive recipients of our health care, not active agents in our health and well-being.
We're talking to Michael Munion, the Pain Project, and you can know more about the Pain Project going to the website, thepainproject.com. Michael, as you were talking, this also came up for me where every time I've had pain, and I've even taken Advil or Tylenol or Vicodin for my operations, or even when I've had alcohol, or I've had gone to meditation and have really been in a calming place. And then when my body tries to come back, like that experience is complete, whether it's given to me by a medication or it's given to me by a state of, space that I was, such as meditation or sleeping and coming back out or whatever it is, I know that there's a part of us that seeks right back for it. So even if I have pain and, I went into a state of meditation, calmed myself down, and as I'm coming back into my body, that experience of pain is there. And I remembered that there was a part of me that just didn't want that to be there versus accepting it. Like I even remember, I don't know if you've seen this or not, there's something that you put in your earlobes. There's a device, I forgot the name, you put it in your earlobes and brings you really quickly to alpha state. And people can get it on the internet. And I even remember using that to just calm me and bring me on the alpha state. And then when it was done, and obviously, I will go back into beta state of the brain, the beta wave, there was this desire. Now, I know that my brain is addictive, and almost all people that I talk to, there's a desire to go back into that, calming state immediately. But then, like you said, our brain immediately goes after a quick fix. Let me have a little bit more alcohol. Let me have a little bit more pill. Let me have a little bit more for something in order to consistently bring me back into that. And I had it as, well, maybe I should give a positive thought and an association to different states and not just this alpha state of always requiring and liking to be in that, calming mode. That maybe if I also liked excited mode, and the same way we were a child. I mean, as a child, we didn't want to be always calm. It wasn't like, you needed to be always sleeping. As a teenager, we wanted actually to be hyped up. We got bored if we got too calm. So as an adult, it's almost like there's so much anxiety out there. And now the only thing I want is to just be calm and not be anything else. And when I try to reclaim all of those emotions, of being happy, being excited, even, sometimes being sad, and even being angry, and, having my brain wave to be attentive in a beta wave, or being calming in an alpha wave. And if I gave it another way of being where all of it was good, and it wasn't just that I associated some things bad and some things good, that I associated, pain bad and calmness good, that if I change those meanings for me, then the way that I was with my body, or the way that I needed to get a quick fix would change. What do you think about that experience as you have worked with your clients in the pain project approach?
Well, I think what you're saying is very astute, and I think in Western culture we like to think of things as either all good or all bad.
Yes.
But this idea of acceptance, and that just because it's good to be in that calm state doesn't mean it's not also good to be in these other states and feel all of that possible emotion. And so when we think about how pain interfaces with the array of experiences that we can have, if we just get comfortable with the idea, and I think in some ways it persists in hinging on understanding the nature of our pain, that what I'm feeling is chronic pain, not acute pain, and that acute pain absolutely needs my attention. If I slam my hand in a car door, it's better not to continue with a conversation and get around to opening the door later. Let's open the door first, get my hand out of the door, and then we can continue our conversation. So acute pain needs immediate attention. And once we get comfortable with the idea that, okay, my hand hurts, my head aches a little, can I continue to do what I need to do and not let that be where my attention is dominating? So that, yes, it's great when we can relax and get into that alpha state, and we may even forget totally about the pain. Truth be told, what that's saying is there are absolutely mental states that simply don't need to attend to the pain. And it's true when we're in that alpha state, but it's also true when we're at dinner with our spouse, or it's true when we're doing a presentation for work, or it's true in all facets of our life, that when we get absorbed in those activities, we can allow that chronic pain to just fade into the background. One of the things, and hopefully this speaks to the phenomena that you're talking about, is that our sensory experience is much deeper and richer than we are able to comprehend at the awareness level. So that for you and for anybody who is listening right this second, if we want to, we can feel the clothing on our body. We can feel where our shirt maybe touches our neck, or we can feel where there's jewelry maybe hanging from our ears, or a watch on our wrist. That's there all the time. Those sensations are available all the time. We would be driven crazy if we paid attention every minute to every physical sensation available. The same is true with auditory sensations. If we paid attention to every sound outside the window, outside the room that we're in, even the conversations of the people at the table next to us at lunch. We simply cannot attend to every physical sensation available to us. Our bodies, our brains already know how to do that. They know how to take what I call redundant information, right? If you feel the shoes on your feet right now, that sensory information has been available to you all along since you put them on this morning. But how annoying it would be if that was brought to our awareness once every 20 seconds. Yep, still got shoes on. Yep, still got shoes on. It would make us crazy. So our brain has the capacity to relegate redundant information to below our awareness, so that we only feel our shoe as the lace comes untied and we go, something's changed, something's different, something needs my attention. We can do the same thing with chronic pain. We do that with chronic pain. When you are in that alpha state, you are simply not attending to the sensory information. It isn't that your arthritis went away for those 20 minutes that you were meditating. It's been there all along, as is the noise outside the room you're meditating in, but we don't attend to it. So I don't know if that speaks to the point you were making, yes. But we can carry that capacity to relegate non-essential information, which is what the non-essential sensory information, which is what chronic pain is. We can relegate that to the unconscious, and we only need to know about that chronic pain when we're possibly doing damage.
Mm-hmm. So, Michael, in the Pain Project, when a person comes to your group, what they can expect is that you help them better understand their pain, their body, emotion, relationships, and the way it works, and the activities and the expectations that they have, and the exceptions that they have when is the pain less. And then, that you guide them toward healing, with cognitive behavioral therapy, meditation, even hypnosis and different types. Develop a plan that they can create with the attainable goal, and then teach them skills to reclaim their life and put them back in control. So we only have a couple more minutes. Can you tell the listeners who are with us how to find you, and what they can expect from your services? Are you only in Arizona, or they can also work with you online?
Absolutely. I'm so glad that you asked about that. I get so excited talking about the phenomena of pain and all this approach. It's very exciting. We're just excited about what's going on here. This is telehealth. And for most people, they've had an experience with video chat with Skype, and of course that's not acceptable in any kind of medical or behavioral health treatment, because those are not secure. What we have established is a HIPAA-compliant telehealth platform. It's called eVisit. They're actually also an Arizona firm. And so we have, right now, we have 10 therapists who are working with us, and they're across the country. And you don't have to be in Arizona. You don't have to be in Pennsylvania. You don't have to be in any of the states where these therapists are. You will be logging in on a HIPAA-compliant telehealth platform. And honestly, that was one more of the things that I brought to the table when I started to work with this project, because I had done telehealth in the publicly funded behavioral health sector. Psychiatrists are so hard to come by in Arizona that when we had remote clinics, we would put our psychiatrists on telehealth platforms and meet with patients, we found that they loved it. And
do
so now
a lot, and it's fantastic.
We're doing that for therapy.
Yeah. And it works. I wrote the book on online therapy, and I do a lot of online therapy, and I think that it really works, online coaching and online therapy. So it has been great to have you. It's great to learn about all the new techniques and new projects that you have. So please, everyone, go to www.thepainproject.com. And I think that is really needed to look at working with your body, having an understanding, and creating a whole new mechanism that is it's safer for the body, and it's certainly cheaper than constantly going to the doctor and getting those pills and then getting addicted to them and then having to go through recovery. And you'll have a better and fulfilled life with knowing the skills that you can own for the rest of your life. Thank you so much, Michael, for being on my show.
Thank you, Foojan.
Take good care, and everyone, create a wonderful day and a week and a year and a life for yourself. Bye-bye.
You're listening to The Inner Voice with Dr. Foojan Zeine, only on LA Talk Radio.